Welcome to this explainer. Today, we're mapping out the exact anatomical journey of vascular access devices. We're going to be starting right at the surface with peripheral lines and traveling all the way into the heart. Whether you're placing these lines yourself or managing patient care, having a really clear mental model of this stuff is absolutely essential. So let's just dive right in. Here's our clinical roadmap for today. We're making 5 key stops. First, peripheral IVs, then midline catheters, PICC lines, central venous catheters, and finally, hemodialysis and apheresis. Let's get started with number 1. Section 1 is all about peripheral IVs, which you might also hear called short peripheral catheters. So peripheral IVs, these range from tiny 24 gauge all the way to larger 18 gauge sizes, and they definitely have some strict limitations. They're designed for really short-term therapies. We're talking just 72 to 96 hours. And because they sit in those fragile superficial veins, you absolutely cannot use them for vesicants. Those are medications that can cause severe tissue damage or blistering. Pushing harsh meds through a PIV is literally like pouring acid into a drinking straw. So you really want to reserve these for basic hydration. When we think about anatomy, these short catheters are optimally placed in the cephalic, basilic, or median veins of the hand and forearm. Now, you always want to avoid areas of flexion, like the wrist. Why? Because all that mechanical movement dramatically increases the risk of kinking the line, or worse, causing some pretty painful phlebitis. Moving on to Section 2, midline catheters. These are the devices that really bridge the gap. Midlines are fantastic because they allow for therapies lasting anywhere from 1 to 4 weeks. You'll typically insert these into the upper arm's basilic, brachial, or cephalic veins, usually using ultrasound guidance and a wire-guided technique. But here's an absolutely crucial rule. Do not hub a midline. That portion of the catheter left outside the insertion site, it's left there on purpose for proper securement and for placing antimicrobial discs. Okay, here is the absolute hard line we have to draw. A midline is strictly a peripheral device. Its tip terminates in the proximal arm right before the axilla. It does not enter the central circulation. A PICC line, on the other hand, travels all the way into those deep central veins. Mixing these two up can severely compromise patient safety, so we've got to keep that distinction crystal clear. Which brings us to Section 3, PICC lines. These are really our central workhorses. Building on that upper arm anatomy we just talked about, PICCs actually utilize the exact same entry points, the basilic, brachial, or cephalic veins. But here is the major upgrade. PICCs come in robust single, double, and even triple lumen configurations. This is a huge deal because it means you can securely run completely incompatible medications like total parenteral nutrition and chemotherapy at the exact same time over weeks or even months, right through a single device. Now, no matter how many lumens you choose, a PICC has one very specific, crucial destination, and that's the carvo-atrial junction, or the CAJ. This is the exact anatomical point where the lower superior vena cava empties into the right atrium. So what's the big deal about this spot? Well, the massive, rapid blood flow right there instantly dilutes harsh medications, which completely protects the patient's fragile vessel walls. Let's follow that pathway for a second. A PICC enters the arm, navigates through the subclavian vein, and then drops right into that deep central junction. During insertion, clinicians often use ECG guidance. They're watching the monitor for a sharp, peaked P wave. That peak essentially acts as a homing beacon, confirming that the catheter tip has perfectly reached the CAJ before even a single drop of medication is infused. All right, Section 4, central venous catheters, or CVCs. This is where we get into deep core access. Unlike PICCs, CVCs completely bypass the peripheral extremities. Instead, they use primary deep access sites right at the core of the body. We're talking about the subclavian vein, the internal and external jugular veins up in the neck, or the femoral vein located mid-thigh. Interestingly enough, when you look at infection prevention, the subclavian site actually has the lowest risk of infection. It provides a much drier environment with less bacterial colonization, plus there's a lot less mechanical movement compared to placing a line in the neck or the groin. To make this deep access even safer for patients who might need therapy for months or even years, we use what are called tunneled CVCs. The line is inserted into the vein, but then it's literally tunneled under the skin of the chest before it exits. This creates a healed tissue barrier that does an amazing job of blocking bacteria. For upper body insertions, the tip still goes right to the CAJ. But if you're using a femoral mid-thigh approach, the tip actually rests in the inferior vena cava, just above the diaphragm. And finally, Section 5, hemodialysis and apheresis catheters. This is our highly specialized high-flow access. You guys, these devices are massive. Instead of standard gauges, they're measured on the French scale, which calculates the outer diameter of the catheter. These run from 10 all the way up to 16 French. They're built from highly rigid materials, which is an absolute engineering requirement. They have to be able to handle the intense, rapid blood exchange needed to clean blood during dialysis or extract plasma during apheresis. Because of their substantial size and those really intense flow requirements, there is just no way these catheters can go into small arm veins. They are exclusively inserted into major central vessels. The primary insertion sites here are the jugular veins in the neck or the femoral veins. Getting direct access to these major vessels ensures the catheter won't just collapse in on itself under the high negative pressure of the dialysis machine. And just like our other central lines, this journey has to end at the optimal location to guarantee ideal hemodynamics. For dialysis, the tip must terminate at the cavo-atrial junction, or even slightly deeper inside the right atrium. The immense volume of the atrium ensures that blood can be continuously pulled and returned without the catheter suctioning right against the vessel wall and causing a pretty serious injury. So we've traveled from a tiny 24-gauge IV in the hand all the way down to a massive 16 French dialysis catheter sitting deep inside the right atrium. You now have the complete anatomical roadmap, and you know exactly where these lines enter and where they absolutely must terminate. The golden rule here is to always choose the least invasive device that safely delivers the required therapy. So looking ahead to your next patient's care plan, ask yourself, are you absolutely certain they have the right line for the right time? Keep advocating for your patients out there, and thank you so much for joining me on this explainer.